Hello, I am Dr. Aizaz from medicovisual.com, and in today's visual lecture we will talk about the metabolic acidosis, and along with that we will also talk about some very important concepts related with it, the anion gap. And anion gap is not just the plasma anion gap that you famously know, the plasma anion gap. There is yet another type of anion gap that I'm sure very few people of you have heard of it, and that is urinary anion gap. And actually, to demonstrate the magic of these anion gap, we will solve this case. So let's suppose here I have an ABG sample, arterial blood gas sample of a patient, let's say a middle-aged woman, and here you can see the different values, the pH values and different ions values of different ions, and along with that we also have some urine sample report here, and we will demystify this one by one. But before that, let's start from the very basic, that if you look at this report, we know from our previous discussion in last lecture we had discussed what is acidosis. So we know that there is a normal range 7.35 to 7.45. This is normal narrow range 7.35 to 7.45 normal plasma pH range. Now if plasma is pH of the blood or plasma is less than 7.35, then this side it is now called acidosis. And of course it is basically the acidemia, and the pathological cause and pathological state that is causing this acidemia is actually called acidosis. So this is simplest definition of acidosis. So in this case, this is basically a case of acidosis. Now the second question is that is this metabolic acidosis or is it the respiratory acidosis? So in this case you can just look at the bicarbonate ions. So here you see bicarbonate is it is much less than normal, so 15. So it is clearly metabolic acidosis. Now, since this lecture is of metabolic acidosis, obviously you know this case would be of metabolic acidosis, so I simply haven't mentioned the PO2. But if I had mentioned the PO2 would likely be low. Why? Because there would be hyperventilation, not PO2, I mean PCO2. The reason it would be low is because of compensation, the respiratory compensation. The person would respire quickly, hyperventilate basically to get rid of some extra acid. So there is respiratory compensatory element that would be there. But this case is truly to demonstrate the power of anion gap. But before that, let's understand what is acidosis and what actually causes the acidosis, the metabolic acidosis specifically. So metabolic acidosis. Now in the last lecture we had seen that metabolic acidosis is non-respiratory acidosis. So any acidosis in which the major cause, the primary cause rather, not major cause, I should say, the primary cause is not PCO2, rise in PCO2. This is not the primary cause. So primary cause is not coming from the respiratory system. It is coming from somewhere else. So that is why I say it is non-respiratory acidosis. But keep in mind, this term non-respiratory acidosis is not a standard bookish term. It is rarely, if ever, used in literature. I think I have seen it somewhere, but it is very rare. It's not a common term. Obviously, the standard common term in literature is metabolic acidosis. So especially in viva, you must use this term. This is for the explanation or pedagogical purposes, right? So Basically, metabolic acidosis has decrease in bicarbonate ion. This is the main point. It is not PCO2, it is decreased in alkali reserve. Obviously, if the alkali reserve is low, naturally there would be acidosis. It's very easy to understand. Now, how can bicarbonate become low? How can bicarbonate become low? So it's very easy to understand if you think about it logically. There are basically two ways to get rid of bicarbonate. One way is that bicarbonate is used up. So excessive use of bicarbonate, excessive consumption of bicarbonate ion, in other words, you can look at it like this. And secondly, that it is lost somehow, and we will see how it is lost and how it is used up one by one. So first, let's start that how it is used up or how it is consumed. If lots of bicarbonate is consumed, it means there will be decreased level of bicarbonate in our blood. Very logical, isn't it? So very simple. If any acid comes in our blood, so it will release H positive. So let's say it was H2SO4. So H2SO4 will release H positive and another conjugate base HSO4 negative, another anion HSO4 negative. Now this H positive is the actual culprit in causing the acidosis. So what it will do, our beloved alkali reserve, the bicarbonate ion, which is acid fighting soldier, it will quickly take action and it will fight with this. Well, actually not literally fight with it, I mean that it will quickly bind with it and neutralize it somehow, and it will convert this complex, both of these basically when they combine, when they chemically react, in other words simply, so they will form H2CO3, which is a relatively weak acid, right? So this form is sort of decreased, the bicarbonate is decreased. Of course, if more and more acid is coming, more and more bicarbonate will become less. More and more bicarbonate will be used up, more and more bicarbonate ion will be consumed. So how can bicarbonate be used up? So it's very logical that there is increased, okay, let's write it here. So there is increased acid in blood. Increased acid in blood. Wow, it's amazing discovery by Dr. Aizaz. Clapping for me. Just kidding. So increased acid in blood, it's very logical. It's not something breakthrough that I have mentioned here, right? So increased acid in blood. So how can blood increase in acid? Increase in acid? How can acid increase in blood? Sorry, I just jumbled up some words. So anyhow, how can acid increase in blood? Again, very simple. So we are huge biochemical machines. We are chemical machineries. We are not static skeletons. We are biochemical machines. We are all the time metabolic machines. We are basically all the time we are producing different chemicals, and all the time we are producing acids as well. So there could be a possibility that there is increased production of acid in our body. Now normally acid is produced from the metabolism. CO2 is produced, but that is volatile acid that is exhaled out. So better term should be production of non-volatile acid, that is non-CO2, non-volatile, and some textbook explicitly mention this term, the production of non-volatile acid. This is amazing that they mention it. It's very good. This should be mentioned, right? So it is not production of any acid. right? So it is increased production of non-volatile acid that could use up that not could that actually uses up the bicarbonate ion, and that could cause metabolic acidosis. So actually, normally there are from our diet, from the metabolism of the amino acids, different amino acids, sulfur-containing amino acid, even sulfuric acid is produced, but that is not a big threat. That is very less likely, if ever, to cause the acidosis. The bigger problem is some pathological states that cause the metabolic acidosis, and we will try to understand those states. But before that, I think let's complete this flow chart. So how can bicarbonate be used up? One thing is that there could be increased production of non-volatile acids, and what are those, how they are produced, we will discuss it. Just give me some time. The other thing is that there could be ingestion of acids or non-volatile acids. Of course, I'm not gonna write it here, please understand that even if I do not mention, it is understood, right? So ingestion of acid or ingestion of or even if taken by IV route, right? So it could be ingestion or through the parenteral route, administration of acid or substances or chemicals or toxins or drugs or poisons, whatsoever substances which produce acid in the body. So this one is relatively very simple. So this is some external acid that is coming, and a common example is salicylic acid, the aspirin. Now salicylic acid is very interesting. It actually is an acid and it produces certain acids, but along with that, it actually directly stimulates our respiratory center and it causes the hyperventilation even before the metabolic acidosis occurs sometimes, right? So quickly it stimulates the respiratory center, so much so that it causes the increased and quickly wash out of CO2, quick and increased wash out of CO2, leading to respiratory alkalosis. And along with that, of course, being an acid, it also causes the metabolic acidosis. So it means it is causing respiratory alkalosis as well as metabolic acidosis. So it is actually causing the mixed acid base disturbance. So I will not go deep into mixed acid base disturbance, at least in this lecture. In future lecture I will slightly touch upon this, but again not in detail, right? So then along with that, there is type of alcohol which should not be consumed, that is toxic alcohol. The alcohol that is typically consumed in bars is the ethanol or ethyl alcohol. Then there is a toxic form of alcohol, the methanol or methyl alcohol. So if someone consumes methanol accidentally or whatsoever the reason may be, we will not go into that. So methanol toxicity can cause production of formic acid in the blood. So formic acid, of course, being an acid, can cause acidosis. Again, a breakthrough stuff, isn't it? Very logical. It is logical. So then there is NH4Cl, ammonium chloride. This drug can also cause acidosis, NH4 positive, the acidic part. Again, very logical and easy to understand. So then we will also discuss that how can the bicarbonate be lost. But before that, I think let's focus here. How can there be increased production of built-in non-volatile acids? Built-in volatile, non-volatile acids. What I mean by this is that there are certain acids that are naturally produced in our body, but they are produced in very meager amounts normally in our body that they do not threaten to cause metabolic acidosis. They are not coming externally from some drug or from some dietary substance or anything. They are built-in produced, homegrown, right? Home cooked. So what are those home cooked non-volatile acid that may cause the metabolic acidosis? Let's discuss that. So let me tell you something interesting and very sad actually, that in type 1 diabetes and very advanced stage, especially type 1 diabetes mellitus, sorry, not advanced, actually uncontrolled type 1 diabetes mellitus. So in that, we have a cell and many peripheral cells. Of course, not all. Brain is an amazing exception, but many peripheral cells. I do not want to go which cells, that this is not the topic of today, but many peripheral cells, especially muscles classically, they require the insulin to cause entry of glucose. So if insulin level is very very low, like absolutely touching the lowest possible level, so then what will happen, that this glucose will not be able to enter the cell. So glucose level will be high, there will be high glucose, but cells are still starving, cells are crying, they are not getting the glucose. That's very sad for them. So then our different regulatory systems and pancreas specifically, that pancreas will release counter regulatory hormones that work opposite to insulin, especially glucagon will release. So actually glucose is there, but because cells are starving, so our body thinks glucose is gone, so it releases glucagon, right? So I hope you got the concept. So glucagon release will do what? First of all, at the liver level, if we talk about liver, if I draw this single cell of the liver, so liver have glycogen stores, the stored glucose form basically. So it will cause breakdown of glycogen and it will release glucose, and of course this glucose will be released in blood. So blood glucose level is already high, so glucagon will cause more rise in blood more rise in level of glucose in the blood, right? One thing is by glycogenolysis, the other thing is that it will create glucose from non-glucose source, non-carbohydrate source. For example, it can break down amino acid and it can break down proteins and form the amino acid, and from amino acids it can form the glucose. This is called gluconeogenesis. So again, more glucose will be there, but still because insulin is not there, cells will continue to starve. Now the real problem starts with the adipose tissue. Adipose tissue, they are full of triacylglycerols or triglycerides. So triacylglycerol, they contain a glycerol molecule, central backbone, and three fatty acids, 1, 2, and 3. Now there are certain enzymes called lipases. They are like cutters. They will, under the action of glucagon and other counter-regulatory hormones, what they will do is that they will cut these fatty acids from here, and fatty acids will be released in blood, and ultimately fatty acids will come in the liver. Now what these fatty acids will do, here starts the problematic part. So if I draw a single cell of okay, let's just draw the mitochondria, a part of mitochondria, simple mitochondria of the liver, right? Hepatocyte. Now in the hepatocyte, fatty acid will come, they will undergo beta oxidation to form acetyl CoA. It's very simple. Then acetyl-CoA should undergo the process of TCA cycle or citric acid cycle. Oxaloacetate should react with acetyl-CoA, and then acetyl-CoA should form different components of different substrates of TCA cycle. But here the problem is that most of the oxaloacetate and other substrates of TCA cycle are gone to glucose towards they are used up in creating glucose by the process of gluconeogenesis. You see, I have first shown that how it triggered excessive gluconeogenesis. So it means acetyl CoA cannot significantly follow the TCA cycle route. It cannot significantly follow the TCA cycle route, mainly because the substrates are deficient here. They are not present in significant amount. And of course, more important rather reasons would be that there are certain enzymes that are deactivated. I deliberately do not want to go into that biochemistry. But for the sake of simplicity, just focus that, and this is true, by the way, I'm not making it up. The oxaloacetate and other substrates are low. This is one of the major reasons besides the enzymatic reasons, of course. So it means the acetyl CoA should follow some other route. Acetyl CoA can go back to glucose again following the gluconeogenic route, right? Gluconeogenesis route, and it does so, but still more and more fatty acids are coming, right? Lipolysis is going on and on. Still more and more acetyl CoA is coming. So then there is another route that this can follow, and this can form the acetoacetyl CoA, and then from that acetoacetate or acetoacetic acid actually, and beta hydroxybutyric acid, beta hydroxybutyric acid, and there is another one, I think it is called acetone. So three major ketone bodies are there. So basically these are the acids, and these acids are keto acids. So please remember that in severe uncontrolled type 1 diabetes, there is risk of acidosis, and that risk is due to the formation of ketone bodies. These are ketone bodies, and why these ketone bodies pose a risk of acidosis? Because they are acids. So acetoacetic acid, for example, it is an acid. It will release H positive, and it will form acetoacetate and anion, an unmeasured anion. Don't worry about unmeasured anion. I am just putting it up right now to make up your mind for an important concept that will come later. So acetoacetate, a negatively charged ion, and this H positive, it will have to be buffered by utilizing our lovely beloved acid fighting soldier, which will form H2CO3. So it means acid is being formed. So one of the way acidosis can be there, metabolic acidosis can be there, especially in type 1 diabetes patients, is DKA, diabetic ketoacidosis. Now the second thing is that normally what happens that glucose, it usually follows the glycolytic pathway. Okay, let's pick it up from here and let's put it here. Okay, so it usually follows the glycolysis pathway, and it forms the pyruvate, and during this process some ATP is produced, and along with that NADH is produced as well. Then this pyruvate can convert to acetyl CoA, and acetyl CoA is, as I told you before, it can go to the TCA cycle or citric acid cycle. TCA cycle. Now TCA cycle will produce lots of ATP, along with that a good number of NADH and FADH2. I forgot that how much is the amount, but anyhow, please know that these are produced and in a significant amount, more than this one. I think two are produced here, but here they are much more. Now this NADH and FADH2, they are like bank checks. They are like bank checks, and in mitochondria there is something called electron transport chain, and these FADH and NADH2 will go to electron transport chain, and they will be converted to NAD positive plus FAD. Yeah, and along with that ATP will be produced. ATP will be produced. So this electron transport chain, it is oxygen dependent. It is oxygen dependent, but something unique about it here is that this is not a typical bank. This is very interesting bank. Normally you go to the bank, you hand over the check, and the teller would sign the check, give you the money, and will sign the check and give you back the check as well. But here the teller is a bit different. It takes the check, hands you over the money, and then somehow converts this check into an empty check. I mean, this check can again be rewritten. This is very unique here. This check, this NAD and FAD, can again go to TCA cycle back, and again, as if this TCA cycle is running, it can again form these failed checks, this NADH and FADH2. This is low energy state, this is high energy state. So this low energy state can be converted to a high energy state. Then after this high energy state is utilized, it is went through electron transport chain, it can go back to this low energy state to form another NADH and FADH2 from the TCA cycle. So if it is important to understand, please note this and listen it very carefully. If oxygen, it is oxygen dependent process. This electron transport chain is strictly oxygen dependent process. So it means if oxygen is not there, of course oxygen will be there, but amount is less, what we call as hypoxemia, right? If there is literally no oxygen, zero oxygen, person will die, but there is less oxygen. That's the whole point. So if there is less oxygen, then what will happen? Then NADH and FADH2 will be sitting here. Now let's suppose the bank is closed. This is just like that. This oxygen dependent bank is closed. So oxygen is like the energy that is used to run the bank, the electricity used to run the bank and ATMs and all that. Let's suppose there is severe electric shortfall or something, that the bank is fully closed, right? So what will happen? Then TCA cycle is producing these checks, but it is not getting a supply of the empty checks to sign again. So after some time, the TCA cycle will stop, or gradually or severely its speed will become very low. It will run very slowly, right? So it means TCA cycle is directly not oxygen dependent, but because it is dependent upon something, by something I mean electron transport chain, so it is indirectly oxygen dependent. It is indirectly oxygen dependent. So it means if this process stops, then this pyruvate will not go further to the TCA cycle. So acetyl CoA and pyruvate will accumulate. So then this pyruvate would follow another route. There is another enzyme called lactate dehydrogenase, and that's a reversible reaction. What it can do is that it can convert this pyruvate into lactic acid, and while doing so, it will use NADH and convert it into NAD positive, which can again form this NADH. So pyruvic acid, actually it starts with pyruvic acid. So pyruvic acid will be converted to lactic acid by utilizing this one. So it is not dependent upon oxygen. This is anaerobic respiration. But the problem is that lactic acid, if pyruvic acid is there, it won't be accumulated, it will go further, right? Pyruvic acid is not a problem, lactic acid is a problem. If oxygen is less, lactic acid will accumulate. So it means lactic acid can be there. And how can lactic acidosis, how can lactic acidosis occur? Let's suppose you are exercising a lot, you are doing strenuous exercise, very hard exercise. So it means that the supply of this route won't be enough, the oxygen dependent route won't be enough. So some of the pyruvate, lots of pyruvate is actually being formed, so it will overwhelm this system. So some of the pyruvate will be converted to lactic acid. But generally in a normal individual, exercise do not cause a significant lactic acidosis, that it usually do not trigger the metabolic acidosis. It does not reach up to that level in a normal person. But the problem is that if there is hypoxemia, so for example, if there is the problem with cardiovascular system, or any problem due to which there is hypoxemia, or if there is, let's say, ascent to very high altitude, that can cause hypoxemia. That is a separate topic, but just to give you some idea that it is basically the hypoxemia which usually causes the lactic acidosis. Then of course it's very logical, what could be the causes of this. Of course, ingestion of these substances, I do not need to explain this. Now let's come to this part. This one is slightly trickier. Okay, let's write it here like this and then try to understand it. So now, how can be bicarbonate lost? Well, what are the sources from which anything can be lost? Something can be lost from our GIT tract, gastrointestinal tract, via the route of feces, as feces, right? So GIT, and I will explain these things, don't worry. Or as urine from the renal, kidneys, renal route, and then from the sweating as well, isn't it? Sweating, what do you think? Yeah, actually it is a valid route of excretion, but when it comes to bicarbonate, it is not very significant when it comes to bicarbonate. First of all, it is not a huge amount of bicarbonate that is typically lost in sweating, especially in comparison to GIT and renal. And the more important reason is that the real risk of excessive too much sweating, especially if there is very hot weather, that is loss of sodium, loss of chloride, these other important ions. That is a major risk, and that can actually cause decreased blood volume, and that can actually cause contraction alkalosis rather than acidosis. So in this case, bigger problem is alkalosis rather than acidosis, and we will see what is contraction alkalosis in the upcoming lectures. So you should not consider sweating as a prominent route of loss of bicarbonate. The route is GIT and renal, and we will discuss how. So if we talk about the GIT route, and I have discussed this in the previous lecture as well, but here let's discuss it again. So a huge GIT tract, a bit out of proportion to make you understand. Yeah, so here we have stomach, and now what will happen, that cells in stomach, what they will do, is that, okay, let's draw it again. Cells in stomach, they will, this is blood. Cells in stomach, they will pick up CO2, and CO2 is small, diffusible, easy, it can easily cross the membrane, small gas, diffusible gas. It will be converted in the presence of water to, and of course, carbonic anhydrase enzyme to H2CO3. Now H2CO3 will form H positive and HCO3 negative. This H positive along with chloride, H positive and chloride, it will come in the stomach, and here again we have now HCl. So H positive is thrown here. The bicarbonate is released in blood. Now it is not the bicarbonate that is regenerated like in kidney. Actually this bicarbonate is sent again, and let me explain this thing to you. So we have pancreas. So pancreas, what it will do is that the exocrine part of the pancreas, it will pick up this bicarbonate. Of course it's a separate mechanism, I will not go into detailed mechanism, but it will ultimately release bicarbonate. It will release bicarbonate, and when it will release, when the H positive, the acid rich H positive comes here to neutralize this stomach acid, this bicarbonate rich pancreatic fluid, bile, will be released here, and it will neutralize H positive. It will neutralize whatever H positive needs to be neutralized, and it can then be taken back in the blood actually, right? So it can be reabsorbed back. Now the problem is that, let's suppose if a person develops diarrhea. Now if a person develops diarrhea and acid is not still coming from the stomach, so person developed diarrhea, let's say, so this bicarbonate is lost, right? The baseline bicarbonate is lost, let's say. Now what will happen? Now when acid comes, it has to release more bicarbonate. So some extra bicarbonate needs to be sent here. So it means, because more bicarbonate is sent here, so it means our body's important alkali reserve is lost. So it means diarrhea can cause the loss of bicarbonate ion. So diarrhea is the major reason, one of the major reason that it causes loss of bicarbonate ion, and by causing the loss of bicarbonate ion, it is one of the cause of metabolic acidosis. The second thing is intestinal fistula. So intestinal fistula is that sometimes in some surgeries, I think I have assisted one of the surgery related with typhoid perforation when I was an intern, or when I was doing house job. So in that, basically from the intestine, surgically a connection with the skin is established, and then a colostomy bag is attached. So this bicarbonate rich fluid can be lost, not can be, it is actually lost in that colostomy bag. So for that, doctors have to account for the pH, and they might give some the regulatory drugs, or bicarbonate, sodium bicarbonate, or citrosoda, or some other drug. The point is that in case of intestinal fistula, the bicarbonate might be lost, and there is some other fistula, that is a fistula between the intestine and the bladder. So again, I will not go into those clinical details, but the idea is that intestinal fistula can cause loss of bicarbonate rich fluid, and which can cause the metabolic acidosis. Now point is, please understand, I will not teach you each and every cause of metabolic acidosis. They are so numerous. My aim is to make your concept clear, to teach you the basic principles, the underlying logic, and then if something unknown comes in your exam or even in your clinical life, you will quickly logically analyze it, and most likely you will come to the right conclusion even if you do not have knowledge about that. So that's the beauty of clear concepts. That's why I focus a lot on clear concept. I can come and just write all these things, I can enumerate these things and just go, right? But that will not clear your concept, and that will not make you a great doctor. But anyhow, let's focus on the second part, the renal part. So if I draw a simple nephron, a single nephron and simple nephron. Now, bicarbonate is continuously secreted across the glomerulus, and it comes into the tubular fluid, and there is the risk that this bicarbonate may be lost in urine. So it means proximal convoluted tubules have mechanism to prevent this. We have discussed it, so I will quickly go through this. So H positive will be released, and then it will react with H positive to form H2CO3, which in the presence of carbonic anhydrase will form CO2. CO2 will come in again, in the presence of carbonic anhydrase will be converted to H2CO3, and again H positive will be released and a bicarbonate will be released. Now this bicarbonate is not same as this bicarbonate, but the net result is that we have gained a bicarbonate which can go into the blood, right? And this H positive will be recycled. So the point is that carbonic anhydrase is causing the reabsorption of bicarbonate. Now, if carbonic anhydrase is blocked somehow, or there might be genetic defect of this enzyme, or there is carbonic anhydrase blocker that may be given as a drug for certain diseases. So carbonic anhydrase inhibitor, for example, what is its name? Yeah, it's a drug. There is a drug called acetazolamide. I think there are some other drugs as well in this category, but anyhow, so acetazolamide, an example of carbonic anhydrase inhibitor. It can, by blocking the carbonic anhydrase inhibitor, it actually blocks the reabsorption of bicarbonate, and by doing so it will cause the increased renal loss of bicarbonate, which can cause the acidosis. So carbonic anhydrase inhibitor, it's very easy to understand. Or it is not just carbonic anhydrase inhibitor, any renal cause, any renal defect actually, which can prevent the reabsorption of bicarbonate, or which can prevent the secretion or excretion of the proton, the excretion of acid due to any reason, right? So that can cause the acidosis, and it is a complex of diseases which we call as renal tubular acidosis. You might have heard of this term. We will not go into that. That is a separate topic. There is Fanconi syndrome as well, but that is an advanced topic. We will not go into that. Another thing is that here we have the distal convoluted tubule, and in the collecting tubules and collecting ducts as well, here we have the secretor H positive. It is called proton H positive ATPase. So this pump actually utilizes ATP to secrete H positive in the tubular fluid, and it is very efficient. Now there is an enzyme, not enzyme actually, there is a hormone called aldosterone, and this aldosterone can directly promote, it does actually directly promote this. And along with that, it has also an action on the sodium potassium ATPase here in the I think principal cells, yeah, and on the principal cells, but that is a separate action. It has to do something with the potassium and sodium balance. We will not go into that, but the point here that is directly relevant is that it stimulates this pump. So it means that the presence of aldosterone can cause metabolic acidosis, right? Wrong. I just wanted to see if you are not sleeping. It is actually stimulating the secretion of proton. It is actually stimulating the secretion of acid, or it is actually stimulating the loss of acid. So it means if it itself is lost, if aldosterone itself is low, then that could cause what? That could cause the acidosis. It does not directly lead to loss of bicarbonate. It does not lead to loss of bicarbonate, but it actually cause gain of bicarbonate. And actually, I think ideally it should be in this category, in the used up category. Why? Because if there is more proton here, okay, let me explain this thing to you. So what will happen? Aldosterone is low, less protons are lost in urine, so it means more proton will be built up in blood, right? There is buildup of more proton in blood. So if more protons are built up, it will threaten to decrease the pH drastically. So our beloved buffer system, the bicarbonate part of this buffer system, it will neutralize this proton while being used up itself. So it means bicarbonate will be used up and there will be loss of bicarbonate. So this is important to understand. Please keep this in your mind. So it means another cause of the acidosis is aldosterone deficiency, and that could be because if the body fails to add the aldosterone, so that add the aldosterone is Addison disease, and that if body fails to add the Addison okay, if body fails to add the aldosterone, then acidosis will occur. So this sort of rhyming I tried to make to keep this in your mind. So Addison's disease, and along with that, of course, if we give Addison blockers like spironolactone, that can also cause this, right? So along with that, another important thing, there is renal failure, a very sad situation where kidneys are failing. Then what will happen? So obviously we know this. I have discussed it time and again in previous lectures that we produce more acid, relatively more acid as compared to the base. So if lots of acids are being being generated, so it means these acids must be lost in urine. So if kidneys are failing, then protons will rise and bicarbonate will also be used up. But the important thing is that it will not just the buildup of proton. There is something that it will also cause buildup of conjugate base as well. For example, sulfates, the anions will increase and different things will increase. But the point is that yes, the renal failure is also important, and I will put it as a separate important category. So renal failure is important cause of metabolic acidosis. Now there is something important for me to teach you, and I will just go into it and then I will explain what is its implication and what is its use. So let's start from the basic idea that in our body or in any macroscopic fluid, the number of cations must be equal to number of anions. By the way, if you forgot, the cations are positively charged and anions are negatively charged. So it means that if I draw the cations, the amount of cations should be roughly equal, roughly, not roughly, actually exactly equal to the amount of anions. So they must be equal. So these are cations and these are ants, cats and ants, right? So it means that some of the cations that we routinely measure in the laboratory, and that are measured cats, MCATs, right? And then there are certain cats which we do not measure in laboratory, and that is unmeasured cats, uncats. Okay, uncats. That's right. Write it like this. Again, regarding the anions, there are certain measured ants, and then there are certain unmeasured ants, and again they must be equal. Okay, so measured cats are here, measured cats, and this is unmeasured cats, which are, by the way, relatively very small in normal circumstances. Then we have unmeasured, measured ants, measured anions, and then we have unmeasured anions, right? Now the major measured cations are sodium, and some labs also mention potassium, but I will just write sodium here. And then measured anions, they are mainly the calcium, not calcium, calcium is not even anion, chloride and bicarbonate, plus unmeasured cations here and unmeasured anions here. Now if we rearrange this equation, then we will get sodium minus bicarbonate minus chloride levels is equal to unmeasured anions minus unmeasured cations, and this is what we call as plasma anion gap. Plasma anion gap. So plasma anion gap is actually the calculation of unmeasured anions minus unmeasured cations. Now, for the sake of metabolic acidosis especially, we can actually remove the unmeasured cations and we can just write it unmeasured anions. They are very low anyways, so unmeasured anions is a rough estimate of plasma anion gap, and I will just tell you why it is relevant with our discussion, why I suddenly drifted to this topic. Actually, I have detailed lecture on this topic, the plasma anion gap. It is called demystifying anion gap, but here we will not go into detail of anion gap. Here we will focus its use in the diagnosis of metabolic acidosis, and let me tell you what is its use. Okay, let's first write it like this. Here I will write sodium and sodium, and here let me write bicarbonate, and here let's write chloride. Yes, chloride. Okay, now the interesting part, that why it helps us, how it helps us. Now you see that, let's suppose diabetic ketoacidosis is there, so beta hydroxybutyric acid is released. So beta hydroxybutyric acid, BHBA, right? Now this beta hydroxybutyric acid will release H positive, and it itself will be converted to beta hydroxybutyrate. It's a negatively charged ion. Now this H positive, it will react with HCO3 and it will convert to H2CO3. It means it will consume the bicarbonate ion. So bicarbonate, it will lower the bicarbonate level. What it will do, it will lower, of course it will decrease the pH, that is very logical to understand, but it will lower the bicarbonate ion level. But along with that, it has also released beta hydroxybutyric acid, which is a conjugate base, and Do we measure the beta hydroxybutyrate, not butyric acid, beta hydroxybutyrate, which is an anion? No, we don't. So it means it is an unmeasured, anion. So where it will go? It will go here, and it will increase, this unmeasured anion. It will increase the unmeasured anion level. So what will happen? There will be increased, if we measure this, if we calculate this, then we will see that its value will be high value. So high value means that there is some negatively charged ion that we do not usually measure in lab, right? So what are these ions, by the way? These are phosphates. Normally these are phosphates, these are sulfates. This is albumin, plasma protein. It is yeah, several different anions. I forgot exactly, but the important thing is that it is also harboring the conjugate bases, and if external or even internal conjugate base come, it can increase this level of unmeasured anion, which will raise the level of plasma anion gap. Normally it is 8 to 16 mg per dl, or some authors write it 8 to 18, or whatever you want to follow, doesn't matter to me, at least. I'm not bothered with it, but anyhow, unmeasured anion will rise. And of course, if let's say external acid is there, salicylic acid is there, or formic acid is there, let's say formic acid, again very simple and logical, it will release H positive, which will consume bicarbonate, and it will form formate. This formate will go here and raise the unmeasured anion. This is very easy to understand. That please understand and keep this in mind, this basic rule of thumb or basic principle, the concept that I am teaching you. Don't try to memorize that, okay, these are the scenarios, these are, okay, in this case there will be high anion gap and there will be low normal. Don't try to memorize it. Try to understand the core logic of this. Otherwise it's a pure torture. Trust me, it is a torture. I can bet that you will easily forget if you try to, even if you dare to memorize it. So don't even dare to do this. This is a dire warning for you. Okay, so I try to understand, a friendly warning, by the way. I am not threatening you. If you want, you can go ahead, but don't. Don't. It's a friendly warning. So anyhow, the point is that in any scenario, in any type of metabolic acidosis, if the conjugate base is also there, if the conjugate base is also delivered along with the acid, what is happening? Along with the acid, a conjugate base is also delivered here, or produced, or whatsoever you want to call it. Basically, conjugate base, whenever it rises, it will cause the rise in anion gap. Then there is the other situation. For example, in diarrhea, here the bicarbonate is simply lost. But along with bicarbonate loss, have we gained some XYZ negative ion, some lactate negative ion, some butyrate negative ion, some citrate negative ion, some negative ion? We did not get any negative ion here. So we did not get any negative ion here. What it means? It means is that it reinforces the principle, the rule of thumb that I mentioned just now, that if there is no conjugate base that is coming or being produced here, then there will be no rise in this thing, the unmeasured anion. There will be no rise in anion gap. So then something must rise. Why something must rise? Please understand that there is the principle of macroscopic electroneutrality. So let me declutter this and let me show you. Okay, let's suppose bicarbonate level was somewhat here, right? So its level decreases, it comes somewhat here. Of course, decrease in bicarbonate means metabolic acidosis. Then the unmeasured anion is not rising, it is stable, right? So chloride ions, let's suppose it stays there, and of course unmeasured anion is not high, then it means that in comparison to the cations, you see we have this gap, this actual real gap. Unmeasured anion is not actually gap. I mean the plasma anion gap, technically it's a misnomer. It is not a real gap. It is not a real neutral due to electrical neutrality. There is no real gap between cations and anions. It is the gap in our calculation or gap in our lab values actually. So it represents this value, the unmeasured anions minus unmeasured cations, or for the sake of simplicity mainly the unmeasured anions. So if this situation occurs, if there is just decrease of bicarbonate, just loss of bicarbonate, and no increase of unmeasured anion and no increase of any other thing, then there would be actual gap that will be produced, and that is not physically possible. So then what will happen? Should unmeasured anion increase somehow? Well, no conjugate base is coming here, so how can this increase? So our beloved chloride will come to rescue and chloride level will rise. How it will rise? Let me explain it to you, but first please understand that chloride level will rise. So chloride level will rise when there is no extra conjugate base is added. How it will rise? Very simple. Our kidneys are there and our GIT is there. So here GIT can increase if bicarbonate is more and more bicarbonate is lost. GIT can increase the reabsorption of more and more chloride, or the kidneys, they can also increase the reabsorption of chloride, or our cells can release more chloride. But the mechanism is not important. Main thing is that by one way or another chloride must increase, so there would be hyperchloremia. So hyperchloremia will be there, hyperchloremia, chloremia, and there will be anion gap increase or normal. Yes, anion gap is normal because unmeasured anions are still almost the same. So normal anion gap. And in the other situation, the chloremia level would be, chloride level would be the same because it is compensated by unmeasured anion. Now chloride do not need to increase itself. So now basically we can divide the metabolic acidosis on the basis of causes into two parts. Now here, because the bicarbonate is used up, but along with that an unmeasured anion is also added. So it means unmeasured anion, it is representing the anion gap, so anion gap will increase. So these are the metabolic acidosis with increased anion gap. So increased anion gap metabolic acidosis, or it is also called normochloremic metabolic acidosis. So now we can divide the acidosis, metabolic acidosis, into two types, the normochloremic as well as the other one is increased chloremic, hyperchloremic metabolic acidosis. And it is in this type of acidosis, of course, you have understood by now that anion gap is normal. So normal anion gap metabolic acidosis. Why normal anion gap? Because no other anion is added, no conjugate base is added, nothing is added. But where is this renal failure lying? Is it in the increased anion gap, or is it in this category, normal anion gap. Now please understand that in renal failure, of course, the problem is with kidney that they cannot sort of significantly reabsorb bicarbonate, they cannot significantly secrete or excrete the acid. But along with that, GFR, glomerular filtration rate, is also low, and several different problems are there. So that is why anions will also build up. So it is not just one-sided problem. There will be anions that will also be built up, and if anions are built up, then it is actually a type of increased anion gap normochloremic metabolic acidosis, right? So this is the basic idea. Now if we come to our case scenario here, it is, now which one is this? Can we calculate this? So here we can, to calculate the plasma anion gap, let's take these values. Sodium is 140, sodium minus bicarbonate is 15, minus chloride is 114. So now if I calculate this, 140 minus 15 minus 114, so it is 11. As I've told you, normal range is 8 to 18 mg per dl, so it is 11. It is still in normal range. So it means that it is not normochloremic, we should actually call it normal anion gap. Normal anion gap metabolic acidosis. Now notice something. You see, chloride level is a bit high. Normal range is 98 to 107. So here it is 114. So chloride level is high. So it is hyperchloremic. Now what can we infer from this hyperchloremic metabolic acidosis? One thing is for sure, just looking at these values, because it is the metabolic acidosis is there, but anion gap is normal. So it means that there is no addition of a conjugate base. It means we can actually rule out, this is the power of anion gap and all this that I am teaching clinically here. So you see, we can rule out all these things, right? Then it means the cause is either in the GIT or in the renal level, right? But actually, can we rule out of these, can we say whether it is GIT or renal cause out of these two? Yes, we can distinguish it, and for that there is another type of anion gap, and that is urine anion gap, urinary anion gap. Now let me explain this thing to you. You see that, and we have discussed it in the renal lecture, that the kidneys, they produce from the glutamine, they produce NH4 positive through multi-step pathway, NH4 positive, which is carrying this proton and of course bicarbonate as well. Now this NH4 positive will come into the tubular fluid. NH4 positive, again due to the virtue of the electrical neutrality, it must be linked with its friend, the negatively charged ion, and that is usually, here we have chloride. So chloride, it will pair up with chloride and it will come out as NH4Cl, NH4 positive, Cl negative. So understand this thing please, that if more chloride is coming, it means more NH4 positive is there in urine. So if we sort of measure the chloride level, and if we can compare it with other ions, we can sort of measure that how accurately or how efficiently, sort of you can say how efficiently the kidneys are getting rid of acid, right? So if more chloride is there in the background of metabolic acidosis, if more chloride is there in urine, not in blood, if more chloride is there in urine, in the background of metabolic acidosis, it means kidneys are efficiently getting rid of NH4 positive, the acid. So then what it means, if I write this equation, urinary Na positive in the urine plus urinary K positive level, potassium level, minus urinary chloride level. This is the urinary anion gap. Urinary anion gap. It's very simple concept. Now understand what happens that if a person is releasing lot of chloride ions in urine in the background of metabolic acidosis, it means what will happen? This value become negative and very highly negative, right? This value will become highly negative. And if there is metabolic acidosis and this value is highly negative, then it means kidneys are efficiently trying to get rid of acid. But if there is acidosis, even then but even then kidneys are not secreting lots of chloride, then this value will remain near 0 or slightly positive. What it means? It means is that kidneys are not working efficiently to get rid of proton. Kidneys are not excreting proton. Kidneys are not excreting the acid properly. Well, normally it is 0 to slightly positive, right? Normally. But if there is metabolic acidosis, it should not remain normal. It should become negative. I hope you understand this point. Now, in this case, what is happening? Let's see. Okay, yeah, so urinary sodium is 30 plus potassium is 20 minus chloride is 85. So we don't even need calculator. 30 plus 20 is equal to 50. 50 minus 85 is something negative. 60, 70, 80, 35. Yeah, minus 35 would be there. So you see it is very negative, minus 35. If it is very negative, it means chloride is very high in urine. It means if chloride is high in urine, we know there must be NH4 positive that would be high in urine, right? So yeah, in some cases it must be falsely positive or negative. We will not go into that, but in the background of metabolic acidosis, it is a great telltale of how efficiently the kidneys are getting rid of acid. So it means if it is highly negative, it means kidneys are working fine. So it means it is not a problem like renal tubular acidosis, in which kidneys itself, in renal tubular acidosis, what is happening? In renal tubular acidosis, or even the acetazolamide drug or aldosterone deficiency, all these renal causes, basically in all these renal causes, what is actually happening is that metabolic acidosis is there, but kidney is not acidifying urine properly. Normally, in metabolic acidosis, kidney must acidify urine. But if there is metabolic acidosis, but still kidneys are not acidifying urine, then it means there is a problem at renal level. Now, because minus 35 is highly negative urinary anion gap, it means the renal part we can safely, in most cases, unless you count for some edge cases, in most cases you can rule this out for this scenario. So it means the problem is diarrhea, most likely. If she is or he is, the patient is like relatively healthy, it is not some severe intestinal emergency, or there is no history of surgery for typhoid perforation or whatsoever, then it is most likely GIT cause, and most common is diarrhea. So you see, the power of this is that I haven't given you any history, I haven't given you any examination points here, nothing at all. On the basis of just these values, you are exactly able to pinpoint the exact cause of metabolic acidosis, and this metabolic acidosis is hyperchloremic. It is normal anion gap metabolic acidosis, and it is exactly which type. It is GIT type. It is most likely diarrhea, or it can be just on the basis of these numbers. If we look at it, it can be actually the other cause, the intestinal fistula, but here we will assume the common one, that is diarrhea. So just on the basis of these numbers, you have calculated, you have pinpointed the exact diagnosis. This is the power of clear concepts. So that is why my lectures are long. I know many people, they do not want to watch these long lectures. They just want to memorize these high yield points. But again, I am warning you, don't go into this trap. Don't do this. Please understand everything. Understand the core logic. Use your mind. Use your brain. Okay, before I end my lecture, another point that I just remembered, that there is a relation of potassium with proton. So what happens if there is high potassium, or what happens with potassium in metabolic acidosis? At the cellular level, if proton is high in blood, it means the cell might take in the hydrogen, the proton, and this proton will then react with intracellular buffers, but it cannot do so alone. It can either bring in chloride inside the cell, or it can release the potassium out. So due to this redistribution, there might be high level of potassium in blood, that is hyperkalemia. But more important reason is at the kidney level. At the kidney level, nephrons, the intercalated cells, what they do is that there is a certain channel, a certain transporter here. What it does is that it secretes proton, and it brings in potassium. So it means if there is acidosis, lots of proton is there. In order to get rid of this proton, then it will bring in the potassium. So there would be hyperkalemia. And now another thing, that opposite is also true. For example, if there is hyperkalemia, so let's suppose there is too much potassium, then what will happen? Then kidneys will try to get rid of this potassium, and while doing so, they will bring in the proton. So there would be acidosis, metabolic acidosis. It's very logical. If you use your brain, use your mind, you will understand what is going on. It's easy to understand. It's not difficult at all. So basic idea is this. Actually, there is more to it. There is role of aldosterone, many other things. But to keep the thing simple, just keep this in mind. That is enough for you. So that was all for today. Thank you so much for watching this video.